number 17 of the House of Commons Standing Committee on Health. Today we'll meet for 2 hours to hear from witnesses on our study of Canada's health workforce. Before I introduce today's witnesses, a few regular reminders for hybrid meetings. Today's meeting is taking place in a hybrid format pursuant to the House Order of November 25th, 2021. Per the directive of the Board of Internal Economy on March 10, 2022, all those attending the meeting in person must wear a mask except for members who are at their place during proceedings. A few comments for the benefit of witnesses. Please wait until I recognize you by name before speaking. For those participating by video conference, which I believe is all of the witnesses, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. Interpretation is available on the bottom of your screen. You can choose either Floor, English, or French. A reminder that comments are to be addressed through the chair, and please refrain from taking screenshots or photos of your screen. The proceedings today will be made available via the House of Commons website. And in accordance with our routine motion, I'm now informing the committee that all of the witnesses have completed the required connection tests in advance of the meeting. Today, we have with us as individuals, Dr. David Greatzer, physician and attending psychiatrist, Dr. Arjun Sejal, the professor of radiation oncology. From the Canadian Federation of Medical Students, Santana Hernandez, President, and Montana Hackett, the Director of Government Affairs, en tant de Fédération des médecins omnipraticiens.
From the Fédération des médecins omnipraticiens du Québec, we have Dr. Annelise Boucher, Director Planning and Regionalization, as well as Pierre Belzile, Director Legal Affairs.
From Health Intelligence Inc., Dr. David Peachy, Principal, and from Sheridan College, Dr. Janet Morrison, President and Vice Chancellor. Thank you to all of our esteemed witnesses and panelists for being with us here today and for taking the time to impart upon us some wisdom and advice as we endeavor to make recommendations to the Government of Canada with respect to Canada's health workforce. We're going to begin with opening remarks from each witness in the order they appear on the notice of meeting. So please limit your remarks to 5 minutes, and we're going to start with you, Dr. Greatzer. You have the floor for the next 5 minutes. Welcome to the committee.
Thank you, and thank you, members of the committee, for the invitation to speak today. I started watching the clock during the day and thinking more about, well, how many more patients? How much time is left in the day? I knew I'd get through it, but I didn't know how I'd feel at the end of the day. And then it just started getting earlier and earlier. And one day, 5 minutes into the meeting, I was thinking, oh boy, it feels like I've been here for a while and I have a long day to go. These are comments that a physician colleague recently made to me. When we speak about recruitment and retention of healthcare workers, we need to think about several things, and they include the psychological needs of our workers. My name is Dr. David Greatzer. I'm a medical doctor and attending psychiatrist. I'd like to speak for a few moments this afternoon about burnout and about mental disorders. By way of background, I work at CAMH here in Toronto, where I serve in clinical, administrative, and educational roles. That said, the views I express today are not necessarily those of the hospital. Let me take a few moments to talk about burnout, and I'll confess my bias. My roles involve physicians, and so I see things through the prism of physician burnout and physician needs, but I think they're applicable across all healthcare domains. As you know, physician burnout is a syndrome that is characterized by three things: emotional exhaustion, depersonalization, and a reduced sense of personal accomplishment. To be a little bit more specific, emotional exhaustion, feeling used up at the end of the day, that there is nothing more to be offered to patients. Depersonalization, when clinicians no longer view patients as being people, but more like objects. and a reduced sense of personal accomplishment. Well, that one is clear, but I would add that it's often combined with feelings of ineffectiveness despite the years of training, despite the goodwill. Though burnout has been problematic for years, as you know, everything with regard to physician issues has grown worse with the pandemic. The Canadian Medical Association's National Physician Health Survey, which polls thousands of physicians from C to C to C, had suggested that about 1 in 3 physicians had been experiencing burnout. That was before the pandemic. As you know, since the pandemic has begun, those numbers have jumped up. The most recent survey suggests that about 1 in every 2 physicians, half of our physician workforce, are experiencing some element of burnout. As you know, similar surveys for nursing, occupational therapy, and other disciplines of healthcare have shown something similar. In other words, a bad situation, perhaps not surprisingly, has grown worse. Let me pivot and talk about the pandemic and mental health disorders. As you know, there's been much attention in recent months to survey results showing that people are more anxious and that their mood is lower. As a psychiatrist, I found this interesting, but not necessarily worrisome for most people. Again, I choose my words carefully. Most people have resilience. And as a result, while the pandemic might be stressful, while they might be worried about making rent, or they might be worried about their employment prospects, they will walk away from this relatively emotionally and psychologically unscathed. But there are groups at risk. I can think of 3. First, people who've had a history of mental health problems. Secondly, those with direct exposure to the virus and illness. And of course, those who have survived the illness. Many of our healthcare workers, too many of these healthcare workers, fall into all 3 categories and are thus at risk or experiencing major depressive disorder, post-traumatic stress disorder, anxiety disorders. The literature suggests that long after the physical manifestations of SARS ended, there were the psychological manifestations. And I think we're going to see something similar with COVID-19. The point is that our problems with COVID-19 will continue after that last patient is discharged from an ICU. But in my closing few seconds, I wish to sound a note of hope. I would suggest that there are things that can be done and that are being done that are thoughtful and practical. Burnout. In fact, a rich literature has developed over the last decade or 2 suggesting steps that can be taken. I think about some of the excellence at my own hospital and some of the work done by people like Doctors Wilkie and Tajirian, who are setting up a peer support group that's been highly effective for doctors. And of course, the treatment of mental health disorders, my goodness, that's my life's work. Never have we been able to do more for people who have mental health disorders. The key, of course, is to recognize these problems and then take the appropriate actions. Thank you.
Thank you, Dr. Greatzer. Next, appearing as an individual, Dr. Segal. Welcome to the committee. You have the floor for 5 minutes.
Well, thank you very much, Mr. Chairman, and it is a honor to speak to you today. I'm Dr. Arjun Sehgal. I work at the Sunnybrook Odette Cancer Center of the University of Toronto. Today, I'm representing myself as a Canadian physician and professor of radiation oncology, subspecialized in the treatment of brain and spinal tumors. To provide context, those of us in this field deal predominantly with incurable cancers like glioblastoma. Cancerous brain tumors are the most difficult to treat, and I have been privileged to treat these patients and try and extend their lives. I've treated patients with absolutely no resources to Canadian icons like Gord Downie, and it is always humbling that no matter where you are in the world or whatever your background, the disease indiscriminately takes the patient's life. The nature of this work is highly stressful and a major emotional burden. Resources were already limited as we all face challenges of practicing in a constrained and publicly funded healthcare system. But the past 2 years of practicing during the pandemic only exacerbated the potential for burnout and system-wide burnout. From the early days of having shortages of PPE while seeing patients, dealing with the potential to expose ourselves, our families, and other patients to COVID, triaging patient care based on COVID risk, and to the current reality of an overextended healthcare system trying to catch up while still managing the increased number of patients needing care with COVID. This is fueling burnout. and burnout is happening at all levels of medical professionals. Moreover, patients and caregivers themselves are burning out, and therefore the realities of the limited resources that we face extend not only to the medical practitioners, but to the patients themselves. Every facet of care is challenged by the lack of human health resources. We are short nurses, allied health professionals, personal support workers, and doctors. Many simply retired, quit, or look for another profession as the environment is just overwhelming and under-resourced. In addition, the system really hasn't provided the additional supports to care for the workers who are at the front line, and the system is trying with new strategies on the fly. But the question is, what can make that difference to help healthcare workers now, as it is not simply recognition. I often reflect that if the system improved the efficiency in which we practice through better modernized electronic health record systems, seamless access to imaging tests like MRI and CAT scans, better approval processes for new life-saving drugs, tests, and specialist care, and staff to help the administration of healthcare, as more and more these tasks are being put on doctors, and that is stressing the system and the burnout. In other words, we need to let the doctors be doctors and ensure clerical staffing is provided by the system so that doctors can look after patients instead of cutting down on patient care to allow time to perform order entry and transcription of notes. This would be a major boon for staff retention, especially in northern and rural settings, and combat what seems to be an increasing proportion of young doctors who are burning out. I'm not an expert nor practice in rural or underserviced communities, but I do care for patients from all over Ontario with rare tumors as a specialist. I can say from my northern colleagues that this problem is much more difficult to deal with in remote centers, as the pool of workers is far less and some core services have had to be restricted. The acceleration of virtual care is helping in managing the current crisis as we do more virtually, but we need a fair system and access to resources that spans not only hospitals, but all care settings, including remote care offices. There needs immediate attention to new healthcare models to manage the limited resources that are getting even more scarce due to the workforce answering with burnout from the constant pressures of understaffing and over-administration. I do believe that increasing the staffing levels will make a major difference, but this will take time. Accelerated programs for recruitment of nurses and long-term workers from other countries may be a solution, but we need to train more young Canadians and make it attractive again to go into the field of caring for the sick and needy. It would go a long way for rural centers to have modernized resources so the staff can work proudly in that setting, be retained, and be able to recruit new staff by offering the latest medical resources like they would in downtown Toronto, so they can do their jobs the way that they were trained to do. Now, this can have a positive impact in terms of the burnout rate and patient care. And to summarize, I would say every healthcare worker, from the support staff maintaining clean surroundings, security personnel that protected us when protests were happening, technicians, nurses, and doctors, we all strive selflessly to provide only the best care for our patients. And that I believe in, and I do believe that it's time to protect us from burnout. And I thank this committee for this opportunity.
Thank you, Dr. Segal. What a perfect segue to our next group. The Canadian Federation of Medical Students. Will it be Ms. Hernandez speaking for the group?
Montana and I will be speaking together. So if you unmute, we have our speaking parts.
You have the floor. Go ahead.
So Masi Cho, thank you to the Standing Committee on Health for taking the time to hear from the Canadian Federation of Medical Students. We are an organization that represents over 8,000 students from 15 medical schools across the country and the future of the healthcare system. My name is Santana Hernandez, and I am the president of the CFMS, and here on the traditional territories of the Treaty 7 peoples of Southern Alberta and home to Métis Nation of Alberta Region 3. I'm joined by Montana Hackett, our Director of Government Affairs and our President-elect, who is joining from the Township Treaty 6 territory in London, Ontario, as well as Treaty 2 territory. As medical learners, we bring a unique perspective to this conversation and are strong advocates for learners and the broader medical educational community. We are aware that our partners at the Canadian Medical Association had the opportunity to speak to you previously, and we hope that our information and asks will build on the information they shared as we echo the incredibly important issues on the health and human resource crisis, the need for investments on a national health and human resource strategy, and national licensure.
perhaps could be confusion on how those issues impact students and what components are missing that impact us as learners. So I want to take a few minutes to break this down for the members of the committee. One thing that is top of mind for all medical learners is the residency matching process. Each year we say trained medical doctors going unmatched to a postgraduate program. Government plays a key role in deciding residency seats at the varying provinces, since those seats are often determined by educational funding and resources to build programs across the country. We only a few weeks ago concluded the first round of the 2022 residency match, and it was a landmark year for all of the wrong reasons. This showcases the urgent need for action from both the federal and provincial governments, both from the standpoint of medical student burnout, prevention and retention, but also resource allocation in a healthcare system that is bleeding workers. If there is a significant need to align the current residency system with the needs of the patient population and the desired career prospects of its future physicians to prevent burnout. This includes government investments in human resource projections, and adequate program funding.
Secondly, there is an urgent need for national licensure. Currently, the application process for medical licensure requires physicians to submit separate applications to each of the 13 provinces and territories' medical regulatory authorities that license physicians. This limits physicians from providing services in multiple jurisdictions without going through a separate licensure process for each province and territory. This poses a challenge to its residents and staff physicians who strive to deliver care to patients easily and flexibly. This includes significant patient safety risks and delays in care, as administrative burden takes physicians away from their primary focus of patient-centered care. Practicing outside of their own province and territory would allow residents to expand their practice to include underserved rural and remote communities. As future physicians, the burden of these applications in the context of all of our other duties and responsibilities is significant, and national licensure would alleviate this issue while also making patient-centered care more flexible and directed to those that need it most. We released a joint statement with the Resident Doctors of Canada, the College of Family Physicians of Canada, the Royal College, the Canadian Medical Association, and the Society of Rural Physicians of Canada, advocating for exactly this several years ago. And there's an increased urgency for this change now more than ever.
Finally, both preventative and reactive mental health supports need urgent funding. In our 2017 CFMS members survey, it was reported that around 37% of Canadian medical students meet the criteria for burnout. This is a staggering figure, and even more frightening as that is a pre-pandemic one. Wesley Verbeek, who was a medical student in 2017, said it best: another problem that students training to care for the mental and physical health of others don't have time to tend to their own health. You have to learn and do so much in a short period of time. There is a lot of pressure to keep going, because the more you can continue the status quo, the more likely you are to get matched to the residency you want. As our former president, Dr. Franco Rizzuti, explained, medical students tend to be high-functioning and highly resilient, but the accumulation of many stressors leads to anxiety, depression, and burnout. Time crunch pressure, lack of sleep, 70-hour work weeks during clinical rotations, witnessing patient death for the first time, personal issues, it adds up. And even the best coping mechanisms can start to fail. With burnout among residents and staff physicians estimated at 50% or above, the emotional struggles of medical students represent the beginning of the pipeline. How are we going to improve overall health and wellness in the general physician population if our trainees, without the stress of running a business, without some of the on-call requirement, have high levels of burnout and depression? So combine the long wait times and inaccessible mental health supports with trainees who, due to the demands of their learning, have limited opportunity to access them, creates a crisis.
So we have three key recommendations: the need for a national integrated health and human resource planning that has an intergovernmental approach spearheaded by the federal government is urgently required. We need to eliminate barriers for medical professionals by enabling the adoption of a national licensure system. Medical professionals need to be able to move from province to territory to help deliver care where it's needed. And finally, increase accessibility for mental health supports, given medical trainees are facing a mental health crisis. We are at the beginning of a lifetime of service to our communities, so implementing these measures now translates into better patient care for all. Working with Blackfoot elders here in Mohkinstsis, the Blackfoot name for the city of Calgary, I have been privileged to have many teachings about the importance of walking a parallel path, and that is what we must do now. We need to work together to create a healthcare system that fosters wellness, sustainability, and takes a proactive approach to ensuring patient safety. We urge you to take action now before it's too late. Our educators need you, and we need you. And this is a nonpartisan issue, and Canadians need you on their team. So Masi Cho, thank you to the chair and the committee for hearing our witness statement.
And thanks to you both. I'm sure there'll be questions when we get to that part of the program. Le tour.
Now on to the Fédération des médecins omnipraticiens du Québec, represented by Dr. Anne-Louise Boucher. You have the floor. Good day. I'm a general practitioner, and I'm the representative from the Fédération des médecins omnipraticiens du Québec. I'd like to start by thanking the Standing Committee for Mr. Luc Thériault specifically, the member from Montcalm, for giving us this opportunity to share our comments as to the issues relating to staffing in Quebec. Our federation is a professional organization representing some 10,000 medical doctors in Quebec. It is recognized by the Quebec government to represent its members in any negotiations. It is not only a union of sorts, it is also an important actor in planning and organizing general medical treatment in Quebec. It is also the most significant, long-standing training group for medical doctors in Quebec. Our association is an essential part of the Quebec medical system. We saw that in the context of the coronavirus. We have shown that our organization is an indispensable partner for politicians and system managers. Our members have shown up for the work that was required. They were able proactively and with great initiative to reorganize frontline services while actively supporting care and institutionalized work, whether we're talking about emergency rooms, frontline work, in intensive care, in long-term care homes, in the CLSCs, in home care, palliative care, at home or in institutions, as well as with respect to medical assistance in dying. In other words, in every area of medicine, our members have delivered the goods. They will continue to do this today. They will continue to do it tomorrow, and they respond to the needs of the public. In Quebec, medical doctors cover both the front line and the second line, and they are more likely to be at the second line. The urgency of the pandemic certainly affected them. It has led to a number of clear evidence of burnout, an increase in the number of hours. It has been very taxing to be constantly adapting with respect to the coverage of care, which was always varying due to the context of the pandemic, and the sudden absence of members of teams because of COVID. All of this meant that all members had to constantly adapt. The exercise of medicine during the pandemic has been affected. A good example is telemedicine. This rapidly changed our habits. In order to coordinate all of these professional changes, the state of our workforce is not optimal. On the contrary, many people are still missing as members of the team. As you've heard over the last few years, there are over 1,000 missing general practitioners in Quebec in order to actually meet the needs that are evident. The fatigue caused by the pandemic over the last couple of years has been one factor, but there's also more administrative burden to deal with. and this means that the profession is less attractive to new potential medical doctors. There is a system to match medical doctors throughout the country, and generally we've noticed that new physicians tend to avoid general practice in favor of other specialties. After the first round, many positions remained unfilled, and we have to remember that one unfilled position in general practice will have a negative effect on frontline access to medicine for 30 or so years. Family medicine in Quebec needs to be valued by medical students. Too many people, especially at the higher level, have denigrated this profession over the last few years, and we know the result of this. As we were saying, there is a significant shortage of general practitioner. Actually, 1,000 are missing, and over the last few years, there have been a number of positions that have never been filled, and even more so the last couple of years. This is just a fact as to our workforce. There is less frontline work being completed in Quebec than in the rest of Canada. Medical doctors in Quebec exercise their profession in 2 or more areas of medicine. We have the lowest rate of general practitioners per capita in Canada. There are 9,800 general practitioners in the Quebec medical system. But there are also many of these doctors who work in emergency rooms or in the CSHLD, which are the long-term care homes, and many in obstetrics. So that represents 30. Some work in palliative care and other areas. So these general practitioners actually work in other areas, as I've said. 30 to 40% of their work is actually focused on other areas, and including working in Ontario. This means that there are fewer frontline medical doctors available to patients. This extends the wait lists, and patients tend to consult their medical doctor multiple times while they're waiting for surgery or to get renewals of prescription. All of this means an increased load for medical doctors, family doctors. And in the remote and rural regions, there are other factors that have to be considered. Although there has been some stability, some areas like Abitibi, Chibougamau, and the Gaspé region specifically are having a difficult time recruiting. In the rural regions today, medical practitioners, as general practitioners, tend to be older. They've spent their entire lives in these areas, and yet they're not attractive to younger doctors. Many younger doctors hesitate to move to very isolated regions, even though they may be close to cities. So there are significant issues with respect to recruiting in these regions. Now, with respect to indigenous communities, Dr. Boucher, you'll have time. There will be time for questions. Do you think you can wrap up? Yes, I will. So we would expect that the federal government should increase the healthcare transfer to the government of Quebec in order to improve support for general practitioners, giving them better support technologically, etc. Also, it's important to make sure that our profession is valued. If it is, it can also be supported specifically through the support of universities, and in order to increase exposure of our profession to the young medical students. We also think another important thing would be to review all the forms and regulations and administrative burden that complicates our work. in the context of the serious shortage of medical doctors. We can no longer do things the way we used to do. We need to delegate. We need to work in collaboration with other professionals and just decrease the administrative burden. And this reorganization of work requires this change management. And this is exactly what will give us an opportunity to do the work that we are actually trained to do. Madison, thank you.
Merci, Dr.
Thank you, Dr. Boucher.
Representing Health Intelligence Inc., Dr. David Peachy, the principal. You have the floor, Dr. Peachy.
Thank you. Good afternoon, and thank you for the opportunity to meet with the committee. I prepared a brief opening statement to provide context, the nature of our work, and the lessons that we have learned, at least some of them. Health Intelligence has undertaken related work with a team of 4, constituted by a project lead, a health statistician, a software engineer, and a project manager. Each of us has consulted in healthcare for 20 years or greater, with the major thrust over the past 10 years being resource and clinical services planning. With varying degrees of scope and intensity, we've completed resource and services plans in 9 provinces and territories. And I do believe that a fundamental aspect of your mandate in this committee is, in fact, this type of planning, particularly in the domains of recruitment and retention efforts, which inevitably founder in the absence of the ability to recruit to a plan. Healthcare systems that are unplanned rarely, if ever, reach full potential. Human resources for health intrinsically are the healthcare system. Without question, technology, beds, and pharmaceuticals are vital to its functioning, but the ultimate quality of care received by the people it serves starts and ends with the quality of its human resources for health. Planning human resources for health addresses the challenge of balancing supply, demand, and need in a highly labor-intensive delivery system. Understanding the complexity of the workforce, the contributing roles of supply and demand in generating shortages, demographic trends, and working conditions are additive in assessing the current and long-term pressures on the workforce. Resource planning and related policy initiatives are dysfunctional without coordination across the workforce. In the absence of health workforce planning as the basis of health system planning, policy, and implementation, the status quo will prevail. And across Canada, the status quo means a largely demand-based system of growth and change in health workforce needs. On the other hand, clinical services forecasting is a forward-looking projection. It's based on assumptions regarding key determinants of population need and workforce supply. Resource and services planning is the process of shaping the future forecast according to organizational strategy, policy, and objectives. And as I'm sure you're well aware, the work of such planning is neither formulaic nor necessarily intuitive. Rather, it is navigational, both seeking information and responding to it. The methodology that we've used for a little over a decade is an adjusted population needs-based methodology, or APNM, that utilizes a primary model that is population needs-based but has specific adjustments and modifications to compensate for known inherent weaknesses. The elements and variables in our model constitute the anchor to underpin the complexity of a rolling 10-year plan with the constant repopulation of the data and the qualitative components as well. The outcoming care is equitable, sustainable, and based on population health needs. This patient-centered care, as was referenced earlier, cannot be achieved in the absence of a collaborative team-based care that's characterized particularly by the role optimization of all providers in the system with measured outcomes, mutual respect, and a shared responsibility for quality. The methodology itself, as it's evolved over the past dozen years, follows a sequence. Begins with a comprehensive data acquisition, collation, and analytics, then comprehensive qualitative inputs based on significant stakeholder engagement and updating our literature database. We assess determinants of need, determinants of supply, and all of these come together to evolve into a preliminary data catalog, and from there, a data compendium. The data compendium evolves into an environmental scan, and the environmental scan evolves into the genesis of innovative models of care. Integrating the final qualitative and quantitative elements of need and supply uses our software in the APNM to generate a forecasting model, including scenarios and simulations that are translated into a base case, a low case, and a high case in the construct of a rolling 10-year plan. So with this context and summary of our approach as the backdrop, following is a non-prioritized, and I stress non-prioritized list of lessons and key points that, if nothing else, have been constants throughout our work. First of all, if it's not being done for the patient, then why is it being done? We have survived, and we're coming out of a provider-centric care system, and hopefully it'll be a patient-centric system. Recruitment and retention of health professionals are unquestionably bolstered when there is a resource and services plan in place. Recruitment and retention are, however, best addressed as separate entities since the drivers differ and are distinct. Rural and remote care does benefit from jurisdictional programs, but requires support with the modern tools of digital health. Recurrent themes across jurisdiction have been collaborative care, mental health and addictions, palliative care, vulnerable populations, public health, maternal and child health, and care of the older adult. These rise to the top in every jurisdiction we've worked. As referenced, and I think it's important to stress, to be successful, a resource and services plan does need to be navigational and not prescriptive. Planning must be customized to jurisdictional priorities and a needs assessment. And for all providers, it's essential to work using clinical FTEs, including an academic mandate. The models of care need to be developed with role optimization of all provider disciplines and a shared responsibility for quality. Failure to achieve advances in models of care perpetuates the status quo and marginalizes non-physician providers. There also needs to be a much greater focus on generalism, and I think that is one of the keys to healthcare transformation. And finally, Chair, this planning that's been described right now is absolutely not an end, but a beginning. Thank you.
Thank you very much, Dr. Peachy. And finally, we have the President and Vice Chancellor of Sheridan College, Dr. Janet Morrison. You have the floor, Dr. Morrison.
Well, good afternoon. I am Dr. Janet Morrison. I'm President and Vice Chancellor of Sheridan College. Our campuses are located on the traditional territory of several Indigenous nations, including the Anishinaabe, the Haudenosaunee Confederacy, the Wendat, the Métis, and the Mississaugas of the Credit First Nation. So thank you so much for inviting me to discuss the critical role played by post-secondary institutions like Sheridan in shaping the future of Canada's allied healthcare workforce. Before I get started, I want to recognize and thank MP Sonia Sidhu for the role she plays in championing healthcare, both locally and nationally. So Sheridan is one of 24 publicly assisted colleges in Ontario. We have over 55,000 full and part-time students enrolled in a variety of degree, diploma, and certificate programs in the arts and design, technology, business, computing, and skilled trades and health space. We have 3 campuses in some of the fastest growing cities in the country: Oakville, Mississauga, and Brampton. Our campus in Brampton houses our Faculty of Applied Health and Community Studies, where more than 3,000 learners are currently enrolled in programs like practical nursing, athletic therapy, kinesiology, personal support worker, amongst others. Our graduates play a critical role in frontline care across Ontario in looking after the health and well-being of Canadians, whether they're seniors, youth facing barriers, or those living with chronic disease. And the applied aspect of learning at Sheridan starts early. Every year, we send 1,500 students to field placements in frontline settings, amounting to thousands of hours of service in the community, from hospitals and pharmacies to long-term care homes, shelters and transition homes, sports clinics in the private sector, such as pharma and health technology. I want to share a little bit about what we're hearing from our students, from our alumni, from our faculty, and from our partners on the ground in the communities on the realities unfolding in their workplaces. Even before the pandemic started, the local municipality of Brampton had declared a health emergency. A lack of qualified and accredited frontline staff to look after the burgeoning and increasingly diverse population of the city was a primary factor. The city, like much of the region around the Greater Toronto Area, was seeing an influx of new families settling in and an aging population that both needed culturally competent care and a healthcare workforce facing a slate of retirements. And then came the pandemic. For a few very long weeks, COVID infections ripped through the heart of our neighborhoods in Brampton, which saw record levels of infections and some of the lowest vaccination rates in our province. Sheridan stepped up to live our commitment as an anchor institution by hosting mass vaccination clinics at our Bill Davis campus in Brampton. While we were happy to provide the space, overcoming vaccine hesitancy amongst local residents required a united effort of social services organizations from the South Asian, Black, Latin, and Filipino communities. The combined interprofessional effort of so many concerned citizens, Sheridan employees who volunteered their time, and organizations helped deliver 35,000 doses into arms and enabled Brampton and Peel Region to overcome what had seemed to be an insurmountable challenge. That clinic was a huge success, but it also taught us some really key lessons. The first, the pandemic has taken a toll on the amazing healthcare professionals who serve on the front lines and the system as a whole. Nothing you don't know. Healthcare needs in the community are rising just as the workforce is finding it hard to attract new talent and retain existing professionals, with so many either retiring or switching professionals. It's anticipated that Ontario will be short 20,000 nurses and personal support workers by 2024. And that was before the pandemic. One local doctor told me he's lost a quarter of his nursing staff in the emergency room. Second, we saw firsthand and heard from so many that looking after the well-being of a growing and diverse population is an increasingly complex task that requires more one-on-one outreach, trust building along cultural or faith lines, and intentional and coordinated interprofessional networks of care. This point was further stressed during a roundtable discussion hosted by Sheridan in January that brought together leading voices from across Peel Region, including hospitals, public health units, long-term care centers, commercial laboratories, and healthcare associations. And third, many internationally trained professionals continue to find it hard to break into the labor market. Given the lessons I've already shared, this makes no sense. Rather than doing odd jobs to make ends meet in order to support their families, many qualified healthcare professionals could be working to serve on the front lines, helping to address the crisis. While I speak from the experience of our place in Peel Region, I suspect the situation is similar in other parts of Canada. I don't think these challenges are insurmountable though, so let me share just a few ideas on what the federal government could do. First, we know that one of the reasons the pandemic hit certain communities harder than others was the prevalence of chronic illness in those communities. In Peel alone, rates of diabetes, osteoarthritis, cancer, and heart disease have been rising for years. We need to focus on future-proofing our communities from the next pandemic by addressing chronic disease. Public post-secondary institutions can play a huge role in that work through our research and our applied approaches to teaching that involve field placements in a diversity of settings, community and industry partnerships, and the use of technology. I know post-secondary education is a provincial jurisdiction, but there are many examples of how the federal government has supported academic institutions in areas like skills development, research, and tech innovation. Second, we already attract a lot of international talent to Canada through the post-secondary educational system and through the skilled workers points system of immigration. In both cases, publicly assisted colleges like Sheridan are often a path to a new career and a new life in Canada. Many of our graduates earn work permits and eventually Canadian residency. Internationally trained immigrants also come to us for upskilling through micro-credentials so they can meet the requirements of Canadian employers. But far too many fall through the cracks. A key pitfall is the lack of consistent and accurate information being provided to individuals in their country of origin by unregulated and often unscrupulous agents before they arrive in Canada. I urge this committee to engage public colleges to be part of the solution in strengthening the channels of communication for prospective visa applicants, whether they're students or skilled immigrants. Another area of great stress for graduates who are preparing to enter the healthcare workforce is housing. Our campuses are located in cities where housing affordability is a huge concern for most people. Solutions that are being discussed have often ignored the student population, whether they're an international student or a domestic student. Limited supply of on-campus and near-campus housing that's safe and soaring rents in suburban neighborhoods are causing many to live in crowded, unsafe rental units. At Sheridan, we want to address housing affordability for students, whether they choose to live on campus or off. While we'd like to be able to afford more options, building and operating new units in the GTA is not financially viable for us without government support. Therefore, we ask that post-secondary institutions be made eligible for capital grants under the Housing Accelerator Fund. And finally, we need to address the critical supports that students need as they transition to the workforce post-graduation. Whether a student is international or domestic, we need to provide the same level of enriched education in theory and applied practices. Both international and domestic students graduating from our programs are ready to help meet the demand for skills in the workplace, and those workplaces urgently need them. Workplaces like the healthcare sector. The federal government can help here by accelerating their careers, making all international students enrolled at accredited post-secondary institutions eligible for the Canada Summer Jobs Program, for example. Doing that would address gaps and needs in local labor markets. It would provide international students with the critical Canadian work experience they need, and it would help them build their path to residency in Canada. They'd also be fairly compensated for their work placement. Let me just assure you that from what I've seen from our international student learners, they're precisely the kind of citizens Canada needs to help strengthen our social fabric and our health workforce. Sheridan is hosting a summit on the international student experience later this summer, open to residents, students, post-secondaries, policymakers at all levels of government, and more. We'd be happy to share the recommendations from that summit with the committee. Thank you so much to the House of Commons Standing Committee on Health for inviting me to provide this deputation today. I applaud you for all of the tremendous work you're doing to improve the lives of all Canadians, and I'd be happy to answer any questions.
Thank you, Dr. Morrison. We're going to proceed directly to questions now, starting with the Conservatives. Mr. Lake, please, for 6 minutes.
Well, thank you all for taking the time to share your experience with us. I'm going to start with Santana and Montana. First of all, there's probably a joke in there about my daughter being a big fan about 12 years ago. As I think about my daughter, who's 22 now, though, and in law school, her first year of law, and I see the pressure that she's under. It's hard when I'm trying to figure out what advice to give her in terms of how much of the pressure is kind of good pressure and how much of it is too much pressure. Because at times it can absolutely be overwhelming and it's clearly too much pressure. To what extent is the pressure in early on in residency, in school, medical school, to what extent is that seen as part of the preparation for the future? Sort of where's that line in terms of that amount of pressure?
Thank you for the question. And you raise an incredibly important point that we face as medical learners. So one of the things that academia has a really great job of doing is adding things with never evaluating whether or not we need to continue to keep some of the things that are still pieces to the puzzle. So what we've seen in medical education over the past many decades is our understanding in science. We continue to make new advancements in healthcare and how we can provide that care. And we never look at the scope of practice of what we're trying to achieve. So as Dr. Peachy mentioned, we need to really reevaluate the amount of time that we're spending on things and the things that we're prioritizing, because one of the key things we see in the way we're done our evaluations is that some of the details that we're trying to look at don't necessarily achieve what we need to do. So antibiotics or pharmacology, for instance, they integrate that into our curriculum. But as we know, pharmacology is always changing. The research is always changing. And there is a multitude of apps that give us that information at the drop of a hat. So is this where we need to be spending our time, or do we need to be developing these skills about how to provide patient-centered care in a good way? So when we're thinking about the pressures that are being put on to us, it comes down to the evaluations, the level of content that we're trying to do, but also the pressures and the experiences of those who are teaching us, because they're under their own burdens as healthcare providers in this system. So when you hear something like the pandemic happening, this is just an added layer on top of what are their responsibilities to provide the training for future healthcare providers, but also to continue to support the healthcare system that we need to ensure that we are successful and that we have healthy Canadians.
Jump in. You mentioned Dr. Peachy and the patient-centered care. And Dr. Peachy, you brought up something that kind of made me write a quick note here and want you to explain further that our system has been, it seems that you were saying, a provider-based system up till now, and it needs to change. Maybe can you elaborate on that a little bit? I think you're muted still.
Thank you. Over the years, without calling it provider-centric care, it has clearly been provider-centric care. And that is because of the nature of how health systems evolve, looking for evidence. And I go back to wise words of Stephen Lewis from Saskatchewan many years ago. And he asked two questions. He said, how would you know if you're giving patient-centered care? And secondly, how would you know if you were receiving patient-centered care? One of the themes that comes out of that, and has certainly been perpetuated through the work we've done, is that you have to ask at the end of the day, if it's not being done for the patient, why is it being done at all? And I think that's the transition that must go forward. It's interesting because in the sort of work we do, you often come against resistance in the early stages. But as it goes on, people embrace change, welcome change, and in fact carry change forward.
Or Dr. Greatzer, I'm going to come to you next and just ask if you want to elaborate on that or anything else that you heard, because you went first with in the testimony, and then all the other witnesses went. I don't know if there's anything you want to specifically zero in on that, or the question about the pressure and how much of that is part of the preparation.
Maybe I'll do all of the above briefly. I think, there's been a certain common theme running through the different testimonies about how the nature of pressure has changed with regard to healthcare. There's more information than ever before to know. That's a good thing. We're able to help patients in ways that we weren't able to help them 5 years ago, 10 years ago. There are higher expectations as the consumer revolution that has transformed other aspects of the economy now transformed the healthcare sector. But with it then comes the challenges of balancing out what we want of our healthcare workers and what we can reasonably expect of them. I think when we talk about physicians, and of course physicians aren't the only healthcare workers, things become even more challenging because we've been taught for so long that we shouldn't get ill, we should simply muddle along, and so on, as though physicians were somehow no longer human and above that. And so when we think about what we want in a healthcare workforce, I think we need to balance these things out and also recognize that while COVID will come and go, healthcare has fundamentally changed. I think for one moment of the way people practiced in the 1970s, and Marcus Welby, MD, was the most popular TV show in North America. Roughly 1 in 4 households tuned into this American show. Somebody had a heart attack, Marcus Welby would suggest bed rest because there wasn't really that much else to be done. Certainly one didn't read a lot of papers in order to prescribe 4 or 6 weeks worth of bed rest. Today, of course, we've got clot busting materials. There's good evidence that antidepressants for people at risk would help the post-MI era. I mean, all of these things come together. So what am I driving at? There's been a common theme of recognition of burnout and mental health disorders, but also a common place for us to need to find innovative solutions as well.
Thank you, Dr. Greatzer, and thank you, Mr. Lake. Dr. Greatzer, I'm getting a note from the clerk and the interpreters. If you could just move your mic up a touch between your nose and your top lip, it's causing a high-pitched sound, and maybe give us a few words there. We'll see if that's better.
With apologies, is that better?
Mr. Clerk? Yep, that's much better. Thank you very much. Okay, now we're going to move to Mr. Van Couverden, please, for 6 minutes.
Thank you, Mr. Chair. Last week, Minister Duclos and Kara co-announced $379 million for the Safe Long-Term Care Fund. Standards have been released and much progress has been made, but the challenge that persists is workforce related, and that's something that we need to address. And the The feedback that we've received so far will guide us in those deliberations, and I thank everybody who came today to provide us with that insight. My question, it will be brief, but I'd like to be able to get to more than one witness, and I only have 5.5 minutes remaining. So I'd ask Dr. Morrison, just a shout out to Halton. I grew up really close to Sheridan College. If you could answer this question first and provide enough time for others to tune in as well. My question is related to the qualifications for foreign trained and educated medical professionals in this country, looking for solutions to attract more talent in the upstream, for students who are currently in high school or perhaps in doing an undergraduate degree. Is good to address this problem years and decades from now, but we have a challenge right now. And I know that in my diverse community of Milton, we have a lot of people who are qualified to be physician's assistants, doctors, nurses, and personal support care workers who are doing other jobs, and they're far more qualified than that. How can the Ontario, but across the country, post-secondary network assist us in training up foreign-trained medical professionals to ensure that we can address this challenge now?
So thank you very much for the question and for your leadership and community presence. You're certainly well known across our campuses. Access is a complicated puzzle. And, what I'd suggest to you is that we have to make it financially viable for learners. We have to think about the red tape. We have to think about regulatory processes in particular. The obstacles, particularly for learners for whom English is not their language of origin, the service that they can provide, the multilingual capacity that they have to deliver in communities, particularly across the GTA, is huge. But we have to figure out how to enable or reduce obstacles to those learners being trained locally. So you need to deliver at night, you need to deliver on weekends, you need to provide English language supports, particularly in, for example, areas of pharmacology. If you still need to study that, think about studying it in a second or a third language. So I think there are lots of opportunities. We need to be purposeful, and we need to think in very broad terms about access. This is low-hanging fruit that I think we can better deliver on. Thank you.
Thank you, Dr. Morrison. I saw President Hernandez nodding along quite a lot, so could I ask if you've got some ideas to share?
Yeah, absolutely. So prior to medical education, I did a lot of work in my undergraduate degree in the province of BC through the BC Federation of Students. And one of the big surveys and studies that we did was around fairness for international students. And I met with students on a regular basis who had the exact training that you talked about, but were unable to kind of make that next step in bringing those qualification forwards. I think there needs to be some key things looked at within immigration policy, because oftentimes we bring them here, train them in certain fields, but when it comes to getting the immigration points that they need to be able to transition, they have higher immigration points by being a manager at McDonald's than they would of being a teller at a bank or a healthcare aide or some of these other components, because the way the immigration scale works in order to give them those points to become Canadian citizens is more fruitful in other areas. The other thing we could do is work with our post-secondary partners to create bridging programs that build in some of that English language competency, but also transitions them to meet the accreditation standards that we have within our programs that theirs may be missing, because there is some differences in the care in which we are learning, but there are some really practical solutions that we have leaders across this country in both undergraduate and medical education that want to see this work come forward. But unfortunately, if we do this work, we don't necessarily have the ability to implement them without some changes taken at the federal government to ensure that we can do that in a good way.
Thank you, President Hernandez, and thank you for your years of work in this field. With about 1 minute and 20 seconds remaining, is there any other witnesses that have any strong feelings about foreign credentials qualifications they could share? Or if the feelings are not strong, they can be medium feelings as well.
Yeah, it's Arjun Sehgal here. I would just say, it's very important to bring in the appropriate professionals, but it's not necessarily just about bringing them in and then going into the workforce. We do have to have a system that can train them so that no matter where they are, patients and communities are receiving the same level of care as if it was a trained physician as a Canadian going through the Canadian medical system, because there are differences. We do see systems where patients are undersurfaced because of the lack of training on the professionals. So I think if you want a system where we bring in more healthcare professionals, which we need absolutely, that it balances out with the increased training that's provided to them so that we're all at relatively the same standard of care.
Thank you very much. I cede the remaining time to the chair.
Thank you, Mr. Van Couverden. Ensuite, c'est le tour de Monsieur.
You have the floor. Thank you very much, Chairman. I'd like to thank all witnesses for their testimony. It's been very enlightening. My first question is for Dr. Boucher. What's interesting here is that we're here in Ottawa, and we know that Ottawa does not have a responsibility when it comes to managing the healthcare system. You talked about increasing the transfers to the provinces, so an unconditional additional transfer that would be delivered to the provinces and to Quebec. In what way would a significant increase in these transfers allow you to really highlight the value of your profession, especially for those regions that are further and more remote? Thank you for your question. I'd like to point out one thing. Transfers specifically with respect to medical school. It seems as though from one medical school to another, pre-doctoral students are exposed to medical doctors from various regions. So if the universities had the required funding to develop either practicums or some kind of systematic introduction in the curriculum so as to give them exposure to general practitioners specifically. Now, with respect to the curriculum, they will be similar in the four large faculty medical schools in Quebec, but there are differences as well. And that could be a factor, meaning that perhaps students might not be exposed to various types of family medicine practitioners. Okay, wait. What you're saying is that there are some very decentralized, regionalized factors that affect your particular field. So people out in the field, in the provinces, from what I'm gathering, are therefore in the best position to develop training that really fits the needs. Correct. Medical schools are able to really develop the curriculum as required because you have to remember that exposure before people are matched either to specialties or to general practice. It's really not in the last couple of months just before they get their doctorate that they will make up their minds. It's done way ahead of that. Often you need to have medical doctors available there who are free, who can come out of these regions. You need to have site visits in a way. You have to do things differently, and that means cost. You need structures, infrastructure, staff, and doctors, family doctors, who can be freed up so they could have students come along with them. Thank you, Dr. Boucher. During the pandemic, the federal government urgently had to, the Minister of Health was proud of saying that it invested $30 billion in the healthcare sector. But now we're dealing with a number of delays, and now we're talking about an extra $2 billion because actually we're in trouble in the hospitals. So what about these transfers that are really sort of one-offs, that are conditional, that really are not very forward-looking or long-term thinking? What does this mean in terms of training our staff or training our specialists? I like your approach that is a long-term approach. You actually referred to a 30-year perspective. You were mentioning it's 30 years that it affects the community. If we're talking about one-time transfers, then really it indicates that the crisis is still ongoing, even though the pandemic is sort of pulling away to some degree, but there still is a lot of work that needs to be done. This field needs to be attractive to doctors and to students. So it is good to have this one-off funding, but it's not significant enough. If we lose one person who could become a general practitioner, it does mean 30 years of lost services. You can imagine what that means in terms of in terms of the population that they're no longer serving over that period. Dr. Boucher, the Bloc Québécois had proposed a summit that would be a national summit on healthcare, where healthcare providers could discuss these issues out in the field directly with the Prime Minister, directly with Ottawa. I know Dr. Amio, your president, was in favor of that approach. Why is it important to raise awareness in Ottawa to the fact that the work that is being done out in the field, you really are the experts in? Look, Canada is a large country. Each province has its own reality, each region. If you have vast pan-Canadian principles with respect to quality or other factors, they have to still be applicable out in the field in these areas, in the provinces, or even in the regions within the provinces, because they're in the best position to really understand the reality out in the field and the specific local characteristics, regional characteristics, based on the type of population, the ethnic groupings, whether it's a rural and remote area or more city-based. Of course, Canada has a role in terms of principles, free healthcare, equitability, but when it comes to the details of how things can be done, you cannot have one rule that applies everywhere. Thank you. Thank you, Dr. Boucher.
Mr. Davies, please, for 6 minutes.
Thank you, Mr. Chair. Ms. Hernandez and Mr. Hackett, if I could address some questions to you first. It's, I think, infamous now that Canada has a shortage of family physicians. Last number I saw was some 5 million Canadians don't have access to a primary care physician, which is pretty shocking for a country that claims to have public universal access to Medicare. I'm just wondering if you could give us a bit of a snapshot representing medical students in that next generation of docs, what the feeling is in medical schools and among your colleagues about whether they're going to go into family medicine, and if not, what are some of the reasons that your colleagues don't go into family medicine?
I can speak to that. It's a fantastic question. I am someone actually who does want to go into family medicine, so maybe I'll be biased towards yes, Santana is as well. And it is, I think, a very good question, and something that, as we've been kind of talking about, is very much specific to the region and to the people who are entering medical school. The conversations around career prospects at medical schools are very much, you need to find the thing that is going to bring you the most joy and the thing that you're going to be the best at, because ultimately, being a physician and different types of physicians is a very personal thing. Ultimately, medical schools are about teaching us to be generalists. We graduate having all the core competencies to be a physician from a generalist perspective. But ultimately, the way we've seen care change over the last 20, 30 years is that because of the quality of care, because of the expansive nature of healthcare, specialists and more and more hyper specializations are required. But at the same time, you mentioned that, family medicine is something that is deeply, deeply needed in this country. As someone who's currently on his clinical rotations, it's something that I see quite consistently. I can, it's immeasurable how many people come into the emergency department or come into, the hospital who do not have a family physician, and the impact on them, not only from a systemic healthcare or systemic factors, but also in terms of preventative medicine, in terms of being able to access care. It's quite devastating for those individual patients. And so from a medical student perspective, it's something that, we all have to consider, what we individuals kind of need, but also, the populations that we're trying to serve need as well.
But unfortunately, there's this hidden curriculum within our educational agenda that we are taught by subspecialists, and a big part of that comes from compensation of how our preceptors are given. So in one thing we hear from our folks in Quebec, from the FMEQ, the student organization that represents the Quebec students, is that our family physicians are actually not compensated the same way as the specialty physicians are in the province of Quebec. So there's less incentivization of them to be a part of teaching us. So if we're not being taught by family doctors, how are we supposed to get excited about, how are we supposed to get students excited about wanting to be family physicians? As someone who loves family medicine, it's the only thing I've ever wanted to do. And as a military medical student, I'm fortunate enough that I get to continue on that pathway. But we need to support our physicians to be able to teach us, to get us excited about it. And that's what we're not seeing, is the support of our physicians who are out on the floor, who are our educators.
Thank you. Now, switching more to the residency, I think you talked about this, Mr. Hackett. I'm curious how many graduates approximately from Canadian medical schools do not match a Canadian residency position and are therefore unable to practice as physicians in that area.
Yeah, you can go ahead, Zaitan, if you want to take that one.
Yeah, just as somebody who sits on those committees, I probably have more numbers at the top of my.
I thought it was Mr. Hackett that raised it, but please, Mr. Hernandez.
Yeah, he definitely raised the point. But so on average, recently we've seen about 70 medical students a year who go unmatched after the second iteration. And oftentimes we do have many family medicine seats that are available, especially in the province of Quebec. They do a better job of making more seats available. But oftentimes this does become a political issue because as you might see in the province of Alberta, our physicians don't actually have a contract. So there's a lot of variation on what their compensation can look like. So that definitely has an impact on people wanting to match to family medicine here in Alberta. And we saw the highest rates, 26% of our family medicine seats went unmatched this year at the University of Calgary, which is the highest that we've seen. And as somebody who wants to match here in the province of Alberta, because my family's here, my ancestry is from the Cold Lake First Nation up in northern Alberta. I would love to be able to stay here and practice here in my province, but unfortunately, it doesn't there's a political aspect to medicine, and that you see here as we're presenting to you today, because there are political pieces that support our ongoing success, and governments decide residency spots. So we need to work with them to develop programs that have seats for students to be able to continue to train them.
Mr. Chair, do I have any time left?
About a half a minute.
Just quickly then, Mr. Hernandez, you mentioned coming from a rural area. We know that Canada already lags behind other member countries in the OECD in numbers of physicians per thousand, but that's particularly acute in Canada's large rural areas. Despite 19% of Canadians living in rural areas, they're served by only 8% of physicians. Any suggestions you might give us about how we can attract young medical students to practice in underserved or rural areas?
I think a key piece of that is giving rural communities access to the resources that they need to provide care. As somebody who had to travel 27 hours to deliver my third child, because I lived in Fort Nelson, BC at the time, and had to travel to Burnaby to deliver my child because that was the only place I could afford to stay with family to deliver somebody. If we had had access to resources there, such as anesthesia, such as ultrasounds, things like that, I had to travel 4 hours for my ultrasound. Doctors don't necessarily want to provide care where they don't have the resources to provide care to their patients, because they constantly feel like they're failing those individuals because they can't do things at an adequate timeline and have to depend on our urban partners to desperately take some of our patients in a reactive manner instead of a proactive manner.
Mr. Chair, maybe the record can reflect Mr. Hackett's enthusiastic head nodding.
Yes, very enthusiastic head nodding.
Actually,
Thank
I'm
you.
glad you got that last question in. That's an extremely good exchange, very valuable to us. So thank you both. Next, Dr. Ellis, please, for 5 minutes.
Thank you, Mr. Chair. Thank you to all the witnesses. Certainly as someone who is a family doctor for 26 years and has been intimately involved with the system from a matter of all aspects of family medicine, this is an opportunity that's near and dear to my own heart. And I guess the real premise for me is I'm not entirely certain that the Canadian population understands the precipice at which we all sit as Canadian citizens with the looming disaster, and that frightens me. That being said, Dr. Gratzer, you talked a bit about a lot about physician burnout, half of physicians perhaps being burned out at the current time. A gross generalization, but if physicians are going to recover from burnout, maybe in a very brief amount of time, you could tell us how that might happen and how long does it take, if it happens?
Sure. Every individual is different and everyone's experience is different, but we do see over the last decade the literature growing much more thoughtful and mature, which is a fancy way of saying other people are looking for answers, and I think there are some. They include, first of all, a culture of wellness, making it possible for physicians to get care and get timely care, and making it acceptable for physicians to want that. We see as well empowerment can be useful. While I am very grateful to be a physician, like others have commented today, there are incredible frustrations, including some very modern frustrations with regard to electronic medical records and the like. Addressing that, sometimes with very simple steps, can be useful. And of course, one can also think about ways of physicians supporting each other, just like other healthcare workers. One thinks about peer support and the like. I guess what I'm driving at is, well, burnout is a very common phenomena. There are very reasonable steps one can take to address it. The key is to do that and to move away from the thinking of not so long ago across North America and across the West, which is doctors don't get sick and we don't need to worry about doctors getting sick. We spend an enormous amount of time today talking about how to get more people in the healthcare workforce. Very reasonable conversation, but I'd impress upon us the importance of retaining those individuals and making sure that they work in an effective and efficacious manner as well.
Great, thank you for that. I appreciate it. And through you, Mr. Chair, to Dr. Segal, you're certainly working in a very sub-specialized area of brain and spine radiation treatment. How are we going to catch up, with respect to the numbers of physicians we're short? I mean, you talked about an electronic medical record, as we've talked about, reduced administrative work, but also we need more people to do the work. How are we going to get them quickly into the Canadian system?
Well, I'll say, one thing that we have noted during the pandemic as a result of the delays is that cancers are much more advanced than they ever were before. I mean, the things that we see are horrendous, and we never saw those. So we're all trying to work to catch up. The hours are really quite long, and we need more staff. And part of it is not just to hire more staff, but actually have the hospitals allow for those staff to work. And so this is what happens where, a certain amount of physicians can do a certain amount of work, but we don't have now the nursing. We don't have the clerical support, and the hospitals try and reduce their budgets by reducing the amount of help that is given to the physicians and to the allied health force. And that increases our burden. And the burden is always in us because we are not employees of the hospital, but our own individuals working within the hospital care. So at the end of the day, we do need to increase the number of physicians to combat the burden, but the system has to ensure that they give us the levels of support to work. Because as was mentioned before, we do everything that we do, but we don't have the support now to fulfill our mandate of caring for patients.
I appreciate it, and we've got about 30 seconds left. For Mr. Hackett, you made one comment that I thought was interesting. You said it was a landmark year for all the wrong reasons. Notwithstanding COVID, I assume you were talking about something else, perhaps if you could enlighten us on that.
Yeah, absolutely. It was in regards to the point about unmatched graduates in our country, and that's something that, as I said, is a significant piece of burnout for students. Imagine going through all of the necessary stages to get into medical school, being in the single digits of people to get in, and then going through medical school, learning everything you need to know, getting your clinical rotations finished, building an application to apply to the position you want to serve your community within, and then not getting it, not being matched at all to anything. And that, I cannot even begin to describe to you how traumatic that is for people. Santana and I have talked to numerous students this year in particular who have gone through this, and it is a humongous source of burnout for students in the medical profession, and obviously, is a waste of resources when it comes to, these are people who are trained doctors at that point who are not getting into the to the system. So,
thank you, Mr. Hackett. Dr. Ellis. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you all the witnesses being with us. My first question is to Dr. Sehgal. Thank you, the hard work you do at Sunnybrook. I just want to echo my colleagues. Many families have been coping with the delays in surgeries and cancer screening. In post-pandemic, we are expecting to see increased rate of cancer with the recent federal investment, $2 billion to tackle this issue. But on the top, what recommendation do you have? And then you also said that to combat this burden, what do you think, how fast we can increase the resources, and then what kind of resources we can, provide?
So that's great, and thank you very much, Minister Sidhu. I think one of the issues is the ICU beds. We definitely have to increase the ICU capacity, and then the surgeries can happen. Alongside with the increase in the ICU capacity, we need the staffing, and that's where we're starting to fail. So we don't have the nurses and the staff to manage the patients post-surgery. So it's a very delicate balance that's going on right now. And I would just impress upon the committee overall that the disparity in various health systems to allow for budget for clerical staff, for nursing staff, and trying to manage the pressures that are on the hospital system are not necessarily helping the backlog of COVID cases. And that's where cancer patients are suffering. So it's harder for us to get tests when we know we need them. It's harder for us to get surgeries. We don't have nursing supports the way we used to. And again, we're being overloaded with the administrative tasks. And if you can ensure that whatever transfer payment comes, that certain amounts are there to allow for those services so that we can do our jobs, that would be very positive for the burnout rate.
Thank you. Next question to Dr. Morrison. Dr. Morrison, thank you for your leadership. We heard a lot in these meetings about foreign-trained healthcare workers not having their train and credential recognized. What role would you like to see colleges playing in resolving this issue and ensuring skilled professionals are in the right jobs?
So thank you for the question. When we hosted the healthcare summit at Sheridan in late January, that was a convened roundtable, as I said. The discussion and the solutions I was quite impressed by, and they're not particularly mind-blowing. So, the problem is one of talent. It is, we think, or we heard, one of scope of practice and ensuring that the full scope of professional practice is duly leveraged. And it is about model of care. So the right care at the right time in the right place. And a lot of the solutions that came to the table from partners focused on many of the themes we've talked about today: collaboration, the use of technology, outreach to underserved communities, and the use of data to inform where we're going and what needs to happen. And I'm compelled to just underscore. I've worked in medical education for about half of my career, my post-secondary career. But the challenges of ensuring that we have the right talent in ancillary services to position physicians and more specialized talent to do their jobs is critical. And an absence of focus on PSWs, practical nurses, administrative medical support staff, I think deserves our focused attention right now.
Thank you. You mentioned the idea of future-proofing ourselves against the next pandemic by focusing on chronic disease. As you know, many chronic diseases is a huge concern in many communities across Canada, including Peel Region. How can governments promote the role of the post-secondary education sector to help meet our shared goals?
So great question. I'm always taken aback when I hear some of the data in this space. You and I are very conversant on the fact that half of adult residents in Peel report living with a chronic health condition, and that South Asians in particular are 15 to 20% more likely to develop diabetes. The diabetes risk amongst Black women has skyrocketed over recent years. I do think there is programming within the post-secondary sector at both the college and the university level that's really focused on education and awareness campaigns, on adjusting perspective, but also lifestyle. And so, across the continuum of care, we need to get people moving. We need to support people in exercising. Our programs in kinesiology, athletic therapy, osteopathy, for example, all of those programs are really intended to support residents before they're diagnosed with chronicity, or certainly afterwards. So I think colleges, institutes, polytechnics, universities can work collaboratively to make sure we have the right talent to be proactive and upstream in resourcing the system, hopefully before it becomes overburdened.
Thank you, Dr. Morrison. And Ms. Sidou, suite Monsieur Garand pour 2 minutes et demie.
Mr. Gall, you have 2.5 minutes. Thank you very much. I'd like to continue with Dr. Boucher. The Canadian health transfer used to be 35% of the system cost. Now it represents 22% and will go down to 18%. I grew up in a small town in the BTB region, and today we don't have a general practitioner. The hospital is closed. There are no birthing rooms. And we know that for families, accessing services is very, very challenging. To you, if the healthcare transfers represented 35% of system costs, would be the upshot for families in these regions of Quebec? That's an excellent question. I think you'll have to be imaginative, because the shortage of workers, that can't immediately be resolved by money, but it will help. There are other aspects that will need to be addressed in the 21st century: telemedicine, networking, doctors that can go work in these regions, but with a structure that means they have people have access to specialists. You can't really ask a number of specialists to be in the BTB region, where perhaps there is not a high population, because they can't maintain their specialties if they're not exposed to enough cases. But if there is a network system, if there are virtual consults, video consults, and even teleconsults, all of this would be significant. It would allow for better services in the regions, in rural and remote areas. But that is, of course, going to involve costs. An increase in healthcare transfers to a higher level would mean that you could have a network that would improve access everywhere. It would take into consideration the fact that the healthcare workforce, just can't be created out of thin air. We can favor some programs. There are many areas where there are shortages. So if there were systems that would mean that there would be greater access, or that at least people who were to go work in these regions would receive support in their specialty to other techniques, access to IT services, or there are so many advances in medicine, remote medicine today. We shouldn't forget this important aspect. And all of that would indeed require an increase in healthcare transfers.
Next, Mr. Davies, please, for 2.5 minutes.
Thank you. Dr. Peachy, to you. We've heard from various witnesses before this committee that Canada, we appear to be drowning in data, but we don't seem to be able to marshal it on a national scale when it comes to managing the healthcare professional human resource crisis in this country. Do you have any insights or advice to give this committee on how we can better use data to more efficiently, I guess, deal with this issue? I think you're on mute.
Spend my life on mute. I think the issue is this: there are really good data out there, but as you've indicated, the data frequently don't get used, and sometimes the data holders are not aware how good their data are. As data starts to get used, people start to get excited about it. But the question about where does it go from here and how are the data used, I think you can look at it in a variety of ways. Go back to the patient-centered care question that came earlier. The data would suggest by all sorts of parameters that that simply isn't happening. And the reality is that when we started this several years ago, we only did physician resource plans until we realized that just perpetuates the medical model. So now we turn down physician resource plans and only do clinical and preventive services plans, of which 50% of that work, and it takes 6 to 9 months at the start of a project, is based on acquiring and looking at the data. Now, it's not purely a metric exercise because you have to have the qualitative component as well. But it is still, the data are generally better than most people think. It's just that they're not being used. And that you can say that about services planning or how we analyze physician compensation. I mean, it goes everywhere. But the data, you're absolutely right. The data are sitting there, almost begging to be used.
If I have time to squeeze in a quick one. You've probably seen a little bit of the problem we face is some people are really fixated on healthcare being delivered provincially, but of course the federal government plays a role in this. It's almost like squeezing a balloon with water in it. If we fix a human resource issue in one part of the country, we could end up affecting another. What's the role of the federal government, do you think, in coordinating a national approach to addressing this issue?
I think the approach,
as succinctly as you could, please.
Yeah, I think the approach is to undergo the analyses that are required to use a single methodology across jurisdictions, and using that single methodology would enable to bring the information together and start to look at it nationally. But as long as we have 13 autonomous healthcare systems, that's not going to happen.
Thank you, Dr. Peachy and Mr. Davies. Next, Ms. Goodridge, please, for 5 minutes.
Thank you so much, and thank you to all of the witnesses for your testimony today. It's always spectacular to have such a different perspective on some of these issues. And I think I'm going to go and touch a little bit, and I don't see on the screen Ms. Hernandez, so I think she might have dropped off, which is unfortunate because I was going to put a plug, and perhaps Montana, you can share with her that on the Cold Lake Fort Wayne base, we have a brand new hospital. So if that's something that she is interested in, we have an amazing brand new health center on the Fort Wayne base. So I would love to have her come a little bit closer back to home. So that would be spectacular. But when you guys were talking about the residency seats and how so many residents go unfilled, I know my riding is Fort McMurray Cold Lake, and so I've got a lot of rural communities and northern communities and isolated communities, and we would absolutely love to have residents learning firsthand in our communities, but I know that there's some challenges with that. So have you any thoughts on how we could improve and increase the number of residents in some of these rural communities?
Absolutely. And yes, Santana had to step out. She actually had to go to another space to talk about this exact issue. But yes, when it comes to engaging residents and medical students in more rural areas, I think ultimately, if you look at it from the perspective of as early up in the pipeline as possible, of course, the best way to recruit people to a region is to recruit the people from that region. And so, the opportunities for people from rural locations to have the opportunity to matriculate into medical school, I think is something that has to be looked at. From the perspective of the federal government, that's about lowering the barrier in terms of cost, in terms of opportunity for people from that region to get the required education to be able to apply and then get in. And that's something we've seen medical schools and admissions start to look at. But it's something that upstream there needs to be much more work on as well. Now, in terms of getting residents, like current residents, in these spaces, I think ultimately it's about investing in having the education available in those spaces. Santana mentioned one of the big things about rural medicine is that they're playing quite often shorthanded in that they don't have the same resources. I, for example, did one of my clinical rotations up in Wyerton, which is not too rural compared to places in Northern Ontario, but there were still decisions that we had to make in management where we didn't for example have a CT scanner that we could go and use immediately, or all of the things in blood work that we can normally do. And so, making these places more attractive for physicians of different stripes by making sure these resources are available to them, I think is one piece. But then also, partnering with the medical schools and investing in more spots maybe in those places would be one fantastic thing to do as well, because ultimately they're trying to allocate spots in their residencies the best that they can based on the regions that they occupy. But at the end of the day, we only have so many medical schools and only fewer spots. So those are a couple things we can do.
Fantastic. And I know I've heard from some of my friends that studied medicine that because the med schools are in bigger centers, once they get used to like the fact that you can get any kind of restaurant at any time of the day, moving back to some of those rural communities becomes a little less attractive. But I'll put a plug in. Fort McMurray has direct flights from Toronto, so you can get home very regularly. Dr. Segal, I saw you nodding along. So do you have anything that you'd like to add?
I just say that I think the point that was brought up was to make these rural communities equipped with the services so that physicians can do their jobs, will reduce the stress on the physicians, and that will improve burnout. Because at the end of the day, what we have to remember is that if the system is not providing that CAT scan, it's still, as the physician, on us as that medical responsibility for that patient. And if something goes wrong, it's not the hospital may or the system may be blamed, but we get blamed. And it's not even just a matter of a lawsuit. It's our own moral blame that we put on ourselves. And that stress is something that most professionals don't really understand. When you couldn't get that test and the person died right in front of you.
Thank you very much, Dr. Segal. Ms. Goodrich, you do an amazingly effective job of recruitment and selling your riding. Well done. Mr. Joe Harry, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses. I'm going to start with Mr. Hackett. Mr. Hackett, so many of us over the last hour or so have talked about the residency match. Can you briefly explain how does the matching process works, and how is it distributed between graduates from our own universities, international accredited individuals who come here that they need to, and also I know a lot of my friends go to US and get their medical degree, and they come back here and they have to do the residency. And who sets these targets, how these targets are set, and who plays a role from a government point of view on setting up these targets, and how federal government can help?
Yeah, I can absolutely answer the 6 questions. Yes, I appreciate it. When it comes to how the actual residency matching process works, essentially in our final year of medical school, we go through an electives process where we choose specific locations and programs that we want to go and visit and rotate through. And then what happens is we accumulate the different pieces of our application and then submit a final rank order of our preferred programs in those specific locations, and then apply to the places we want to apply to. We then are hopefully given an interview at those places, and then we submit our final order of preference, and then the programs also submit their final order of preference for candidates. What ends up happening is those orders, as well as our applications, go to an organization called CARMS, the Canadian Recipe Matching Service, and they do a great job of running an algorithm that matches the student in the program based on those factors that I outlined. When it comes to the role government plays, I believe that was the next part of your question, right? With how government.
Someone you had indicated that it is the government who decide, determining the number of spots. Which level of government is making that decision?
Yeah, absolutely. So that is at the provincial government's discretion. Essentially, how it works is there is supposed to be a health and human resources allocation for these spots, where they look at the needs of the communities, as well as the need for specific types of physicians in those places, as well as predefined spots in the terms of specialists. And then those spots are what is then available for application to. Unfortunately, my understanding is that this doesn't actually happen as much as it needs to. And so oftentimes we're applying to processes that, are out of date, that being that the positions that we're then applying to are not necessarily ones that are, representing the need in that particular time. And so how government kind of is implicated in that is through, one, running that model, but also funding the spots based on the needs of the community. And so that is the provincial context. But as was kind of mentioned before, the federal government has to look at what the needs are of our pan-Canadian system in a way that, the provincial governments can't always do in their own context, so that they're leading what we need as a country and giving the provinces the tools that they can use to then fill their specific needs based on the context that the federal government is working in. I hope that answers all of your
Thank you.
questions.
Would you recommend that federal government ties some of its transfer funding to setting some of those targets specifically in support of the provinces opening up some of these spots?
Mm-hmm. It's a tricky question. I think ultimately, it's something that should be looked at, but it also depends on how that's done. The provinces in and of themselves know their contexts best, or should, and they should be collaborating with, specific regions, the medical schools in those regions, as well as the communities. But at the end of the day, like I said, if there is an opportunity to establish some national priorities, and if those priorities have to be fulfilled by attaching that to a transfer, then I think that's something that should be looked into. But of course, the devil's in the details when it comes to something like that.
With 30 seconds left, I'm just going to quickly go to Dr. Segal. Thank you very much for the great work that you and your team are doing in Sunnybrook. I have a number of very good friends, Dr. Piersman, who's also at Sunnybrook. Quickly, you touched on technology, and I know you've been working on a newer technology, MR Linac, that is supposed to expedite the process of imaging. Can you touch on that and see how is it going to help us clear some of those backlogs? Thank you.
Right, so thank you very much. And the MR Linac technology was one that we brought here as the first in Canada to try and gain a technological platform to reduce the number of treatments. So instead of 6 weeks of radiation, now we can do it in 1 week. And that's what we're realizing. But what's important here is, how did we get that technology? Well, we had to raise money through philanthropy. We had government grants. We basically went to our hospital system and begged them for some money, and they were totally happy to provide innovative funding. But it is a conjunction of philanthropy, government grants, and hospital budget that brought it together. And there's not that many places that can do it like Sunnybrook did. So so although we did do something amazing here in Sunnybrook, it's not something that necessarily can be emulated all across the country. And that this is where the fairness comes in terms of resource allocation.
Thank you, Dr. Segal and Mr. Johari. Next, Mr. Lake, please, for 5 minutes.
Thank you, Mr. Chair. This is a great meeting, and I wish I had a 10-hour round to ask questions right now. But we've been talking a lot about problems and challenges over multiple meetings on this, and I feel like sometimes we don't spend enough time actually talking about potential solutions. And I'm thinking a little bit about sort of measurability and what does success look like. And I don't know. Maybe I'll ask that as a fairly broad, open question, starting with Dr. Greatzer. What might success look like, or examples of success?
You've got actually two questions here, right? One is, how would we measure it? And I think that's an excellent question, because if we don't have metrics, how do we know if what we're doing is meaningful? I would suggest over time, national metrics on burnout would be appropriate, which would also bring accountability both to the federal government and the provincial ones. But you're also suggesting, where can we look for ideas and experimentation? And here's something I think important to consider when we think about burnout. We don't necessarily want to be too creative or too innovative. Let's plagiarize ideas from our jurisdiction and other jurisdictions where they found innovative ways to help people, particularly physicians. Again, I've touched on a couple of these things, and I don't want to use up all of your time. Communities of practice, finding ways for physicians to feel more efficient. Those are good examples. Making it easier to access care as well, given the stigma, particularly within physician bodies, to accessing care.
Dr. Segal, to you, because you talked about efficiency, and I wrote down like tools to let doctors be doctors, which just it seems like that was sort of echoed throughout the conversation today. What examples might you point to in that way? Where are the most egregious examples of doctors spending time on things that doctors shouldn't be spending time on?
Well, I can tell you, just even in terms of my own family life, my wife also works at Women's College and has an electronic medical record, and she's up for hours just inputting patient medications, making sure she faxes the note to the appropriate physicians, typing in the fax numbers. And our system here at Sunnybrook is a bit different. We don't have that. And, we use various different strategies that are efficient so that I don't have to spend those 4 hours after my clinic doing administrative tasks. So if you could tie in part of the funding that gets allocated towards supporting the key initiative of electronic medical records, because it is a key initiative to improve the flow of communication and patient care all across the country, but make sure that there's budget within the system to help us manage the electronic medical record. This will be a huge positive development in the healthcare for patients across the country.
I love the fact that when I talked about efficiency, you brought up your wife and sending faxes, which that's awesome. Did anyone else? I was going to go to a different question, but I'm wondering, Dr. Morrison, you were kind of nodding along with that. I don't know if you have anything to add, or if Dr. Peachy has anything to add.
No, I do. Sorry, I do think there are ways to measure what progress needs to be made, and I'd go back to the internationally trained professionals. We have experience in IEP advancement, regulatory oversight, the reduction of red tape. We have that in non-healthcare environments. Accounting comes immediately to mind. So there are ways to measure that. How many are in the pipeline? How long is it taking? Again, this isn't rocket science. I think it's about concerted effort and about a shared sense of urgency nationally.
If I could add one thing to that, there are a lot of metrics that are very useful, and they can be at an individual level, across specialty, they could be geographic. One of my favorite are the ambulatory care sensitive condition rates, which are measures of people who are admitted to hospital that likely would not have been admitted to hospital if they had timely access to a primary care physician. And it's a pretty good tool to say what's going on.
Thank you, Dr. Peachy. Next, we're going to go to Dr. Hanley, please, for 5 minutes.
Thank you very much. I feel very much like Mr. Lake in this has been an excellent testimony from all around the table, and it's hard to know where to focus one's 5 minutes. I do think I will start with Dr. Segal, and I find that even though you are in a hyper-specialized practice, you spoke very eloquently about rural needs, and we have this almost a dichotomy between the need for super specialization, is particularly in our modern age, but also the need for that broad spectrum of practice. So how can, particularly with a rural remote lens, how can we best optimize that mix between broad generalists in medical practice and finely honed specialists?
Well, I think, it's new models of care that are important. I think we have to start to look for those ways in which we can balance the specialist being in the big city where we have all the tools to do our work, but supporting the rural communities so that care that can be delivered there can be delivered there. But the challenge is that we can only do so much. And there's a lot of that work that is just part of being the physician, but not necessarily remunerated, not necessarily as our physician remuneration, but also to the hospital system remuneration. So there's a lot of changes that need to be in place in order to do that outreach and maintain that outreach. I'll give you a quick example of one of my particular areas, which is brain radiosurgery or focused radiation. So what we did is we went out there and on our own, we went and taught all our communities, whether it's Kitchener, Kingston, going up north to Sudbury, and I do lectures with them and I try and bring technology to them so that they can do the treatments there. But when they need the help, we're here when it matters most. They can call in, they can reach me 24/7, and we'll do it. But not all places have physician champions, and to foster that model so that rural Canadians have just the same level of access as they could right here takes a lot of work and effort and a new model of care.
Thank you, Dr. Peachy. You may or may not remember. I was in Yukon as a practitioner when you did some extensive data work in Yukon, which I think shed a lot of light on what the needs were. But I wonder if you could talk about some examples of where that deep data search has really clarified the needs around provider mix and how we can really elevate that conversation around the country.
I'll give one example of which there are many, and I would be very interested if Dr. Greatzer had a comment on it. One thing that we've found constantly, wherever we go, is that mental health and addictions are a real problem. Not in just the incidence and prevalence, but also people that really need to see a psychiatrist often have unconscionable delays and with serious consequences. On the other hand, the number of people that a psychiatrist perhaps needs to see, that he or she doesn't have to see everybody that comes through the door just because of referral. So the model that we did, we looked at the data on that and started to advocate this in Manitoba, I believe, and that is to enhance the use of clinical psychologists, not only in positioning in primary care offices, where a patient coming in that needs that sort of assessment can get it the same day. Just go to the next office. Similarly, that clinical psychologists can be a filter for those patients who are referred to psychiatrists. And if the patient needs to be seen tomorrow, the patient gets seen tomorrow. And if there can be a delay, you can delay it, or you can go back to your family physician. So whatever discipline in medicine you want to look at, the data that underpin those sorts of decisions can be extracted and they can be used.
Thank you. Mr. Casey, Mr. Chair, if I have any room for Dr. Gratzer to perhaps provide a brief follow-up comment in that regard.
Please go ahead, succinctly, please.
I agree. I mean, I think we have to be smarter about who does what and when. I also, by the way, think that would contribute to better overall well-being if one sees cases that more aligned with one's skill set as opposed to just anyone who was referred. I mean, in some ways, our healthcare system has evolved much from the 1950s, where a secretary calls a secretary and books an appointment, to maybe being replaced by the fax machine, which isn't necessarily replaced by anything just yet. But I think these things are worth considering. Studies show, as an example, that nurse practitioners might be able to do better histories than certain specialists, more available and more thoughtful about details. So, yeah, I think these things are good from a system point of view, but also good from a mental health perspective in terms of contributing to well-being. I mean, I remember I worked at a clinic once where they often would ask me to see people who are interested in couples therapy. I had no issues sitting down with such patients. We didn't offer couples therapy. It was, in a sense, a waste of their hour to sit with me and talk about these things. And it didn't make me feel any better either.
Thank you, Dr. Hanley, Dr. Greatser. Mr. Caron, or...
Mr. Carroll, you have 2.5 minutes. Thank you very much, Mr. Chair. Dr. Boucher, I'd like to start by thanking you for being here with us, for having shared your expertise and your opinions. You're testifying before the Standing Committee on Health in the Canadian Parliament, and the people listening to you are, of course, parliamentarians who have the power to change things and actually a duty to improve the quality of life of Canadians and Quebecers. In closing, I'd like to know what message you would like to convey, what you'd like parliamentarians to remember from your testifying here. Thank you for your question. So really these things, support to the practice, Dr. Siegel mentioned this numerous times, non-medical tasks, so any manual administrative task that could be IT based should be done by another professional other than a medical doctor. Other than that, technology to provide care to people in rural and remote regions. If the technology exists, the support exists, telemedicine exists, allowing for specialists to access these areas and people to access them, so that family doctors would be interested in working there because they would feel supported, they wouldn't feel all alone there, and in a way, I can't remember who was saying something, but there was a fear of a complaint before the board. So these are the aspects to remember. Of course, I am convinced that the regions and the provinces are better equipped to understand the situation in their regions than a major pan-Canadian group. Of course, you need to have some standards, some theories, but at the local level, it has to be done by people there. In reading your brief, I understand that your organization is also asking for an increase in the healthcare transfer so that there can be funding that would be unconditional, stable, predictable, and long-lasting. Thank you very much.
Merci, Monsieur Garon.
Thank you, Mr. Garon.
The last round of questions will come from Mr. Davies, please, for 2.5 minutes.
Thanks. Dr. Peachy, Wayne Gretzky famously said that the trick was to go where the puck was headed. I think the corollary to that is it's important to know where we've come from in order to avoid problems in the past. And I note that in June 2010, this committee tabled a report entitled Promoting Innovative Solutions to Health Human Resources Challenges. And in 2011, the federal government launched the Health Human Resources Strategy to, quote, attract, prepare, deploy, and retain highly skilled healthcare providers to give Canadians access to appropriate, timely, effective care now and in the future, end quote. That was 11 years ago. In addition to the federal role in providing funding for healthcare, the government also provides support to the Federal, Provincial, Territorial Committee on Health Workforce Committee, and in 2005, launched the Pan-Canadian Health Human Resources Strategy That's 17 years ago.
Appel au règlement, Monsieur le Président. On a l'absence de traduction.
There is a lack of translation. Thank you, Mr. Caron.
Mr. Clerk, can you just check and see if this is something that is that we're going to be able to resolve fairly quickly, because we're almost at the hour.
C'est revenu, Monsieur le Président. Merci.
It's back, Mr. Chair. Thank you.
Go ahead, Mr. Davies.
Thanks. Dr. Peach, I'll just, for purposes of my Francophone colleague, in June 2010, this committee tabled a report entitled Promoting Innovative Solutions to Health Human Resources Challenges. In 2011, 11 years ago, the federal government launched the Health Human Resources Strategy to, quote, attract, prepare, deploy, and retain highly skilled healthcare providers to give Canadians access to appropriate, timely, effective care now and in the future, end quote. 17 years ago, the federal government in 2005 launched the Pan-Canadian Health Human Resources Strategy. I'm just wondering if you can give us any insight as to why basically the last 15 years have been unsuccessful in us dealing with the issue of human resources in the healthcare sector, and what advice you may have going forward to avoid the problems.
I expect the main reason is that there are complexities, as there always will be when it comes to dealing with people and energies and determining supply and determining need. And it can be expensive, but the reports that you've listed have fundamentally not gone anywhere, which is why we're still dealing with these things today. And I think that there is, at the same time, there's an enthusiasm to make change, and people are not afraid of change anymore. One of the better committees that I've been involved with is the Committee on Health Workforce at Health Canada, which has got really strong representation. They've been sideswiped by the pandemic, but their reporting line is to the Council of Deputy Ministers of Health. And I think when there's an opportunity for their voice to be heard, they have many things that can be said. And if the CDM can grab it and run with it, then I think we'll see change.
Thank you, Dr. Peachy and Mr. Davies. That concludes the time we have for questions, but I would ask my colleagues not to run off. We're going to thank our witnesses, and then there's just a couple of administrative matters I want to deal with very quickly. So to all of our witnesses, as has been said several times in this session, this has been an extremely thoughtful and informative discussion. We very much appreciate the way you've handled the questions, the depth of your experience, and your willingness to share that with us. We are basically rapidly approaching the end of the witness testimony part of this study. And it's as a couple of my colleagues have indicated, we could do this for another 10 hours. As every time you peel back the layer of the onion, there's something else there. So thanks again for being with us, and for a very productive and interesting meeting. Colleagues, there are two matters that I want to raise with you. One, the committee has passed a motion with respect to the 988 suicide prevention line, and normally, so that the passage of that motion is on the record, and we therefore are now in a position to receive briefs from the public, but we haven't done what we usually do, which is to specify a limit on those briefs. Traditionally, our limit is 2,000 words. Is it okay with everyone if we let it be known that the limit for any briefs to be submitted with respect to that item is 2,000 words? Mr. Barrett, please.
Yeah, thanks, Mr. Chair. I guess I would just defer to the analysts, just based on the limited amount of time that we have. And so if your recommendation is informed by same, then certainly we support that. Just not a ton of runway before the end of June, and lots of reports being prepared concurrently.
That's exactly where the suggestion came from, Mr. Barrett. I can assure you that's why I've put it out there. Okay, do we have consensus in the room, or is there
yes,
need to...
everybody in the room is good.
Okay, thank you. Last item I have mentioned, but I want to put this to bed. We are we are being visited by a delegation of Finnish parliamentarians on May the 11th. They have asked to speak with the Human Resources Committee and with the Health Committee for 1 hour on May the 11th. So I again want to, even if it's by show of hands, indicate whether people would be willing to give an hour either at noon or at 1 p.m. on May the 11th. To have a chat with the delegation of parliamentarians from Finland. Lunch will be provided. This won't be a formal meeting of any sort. It would be in person only. You'd be provided with biographies ahead of time, but there isn't a plan for it to be public or to be recorded. Simply an exchange of ideas and Q&A, if you wish. Is there an appetite for that, I guess, would be my first question. And the second is, does anyone have a strong preference as between noon or 1 o'clock for a 1 hour meeting with the Finnish delegation on the 11th?
Mr. Chair,
Mr. Davies.
Yeah, I think that's a great idea. I'm just wondering, Mr. Chair, what your thoughts are. Our normal meeting would begin at 12:30. So and of course we have question period. Oh, pardon me. I'm in Vancouver. I'm on Vancouver time. Scratch that. I'm all in favor.
Thank you. And there is
Monsieur le Président, peut-être
just a question, Mr. Chair. Will there be interpretation at that event? Can we make sure that there will be?
J'observe le greffier.
Yes, I'm looking at the clerk who's saying yes. I think it would be unacceptable to have a parliamentary meeting without interpretation.
Je suis en accord avec vous, merci.
I fully agree with you, thank you. The answer is yes.
Okay, I see that we have consensus. So unless there's any strong opinions, I'm going to suggest noon, and that the HUMA committee can come in after us. That way we'll get the best lunch. Is there any further, is it the will of the committee to adjourn the meeting? We have consensus. The meeting is adjourned. Thanks, everyone. Have a good evening.